Good evening, everybody. My name is Chanel
You will learn.
Jones. You may recognize me from the Today Show. I host the third hour of the Today Show. I am not a doctor, but the wonderful physicians and the organization blackdoctor.org has agreed to do this event this evening, and I am so thrilled about it. This is all to follow up the documentary that I executive produced, first time for me, that aired last night on MSNBC. It's called Stories We Tell, The Fertility Secret. And so this evening, I plan to take you a little bit behind the scenes as to how we came up with the idea to do this documentary on fertility. And to be quite honest, look, I had 1 hour, 14 hours worth of content. I had to whittle down into 1 hour with commercials. That's 44 minutes. And after we finished the project, I started to feel like I wish there was a way for viewers and men and women and people who watch the documentary, or you, even if you haven't had a chance to see it, I was hoping that there would be a way for fertility specialists and top physicians around the country to answer your questions. And that is exactly what tonight is all about. So if you know someone who is exploring her fertility options, if you know someone who is thinking about freezing her eggs, anyone with fibroids or endometriosis, anybody who has suffered miscarriages or has questions about surrogacy, any of those things under the fertility umbrella, you found us. But feel free to grab your cell phone, text some of your friends, text people you know, and let them know to come to this Facebook page because we'll be talking over the next 60 minutes or so. And as you see here, we have the chat box open. So as soon as you think of your questions, it may be about last night's documentary or just fertility in general, we have some physicians standing by to answer your questions. So briefly, I'll just tell you a little bit about how this all started. Again, I host the third hour of the Today Show. I've been there for about 8 years. But this has been on my heart, frankly, for decades to do. I am 43 years old now, and I remember, gosh, maybe 20 years ago, working with people in the news business and friends who would have fibroids and who would have surgery, and they would go off and have these surgeries to remove the fibroids and then be back at work in a couple of days and pretty soon, in pain, but still at work and not telling anybody else but me what she was going through. And at the time, we just thought it was what she needed to do to keep moving forward. It never crossed our mind that these surgeries and some other challenges could cause fertility challenges literally 10, 20 years later. So that's part of the reason why I wanted to do this. And I have so many friends, from egg freezing to women who, you work all your life trying not to get pregnant, to do all the right things, and then, go to school and find Mr. Right and all those things. And by the time you find that person and you guys are ready to start a family, I can't tell you how many friends I've had who run into problems. And so I just felt like enough was enough, and it's time to talk about it. And it's interesting because I think over time, we're starting to hear more about infertility. But I felt like, when I was flipping through magazines or even doing shows on the national platform, I didn't see women like me. I didn't see women of color. And I know we're having challenges. And so all of those things combined, I thought, you know what, maybe I should do something. And so I sat on it for a really long time. And then the pandemic happened. And I think a lot of us, when the world pushed a pause button, a lot of us had time to soul search. So I pushed the pause button on that. And then George Floyd happened. And I think with that, it was a reckoning for a lot of us, even in the corporate space, about our voices and using our voices in the right way. And so it was almost like so many layers. By the time you add them on, I thought, you know what, now is the time. And I think society is ready to hear a story like this. And, I intentionally asked for my circle of friends. They are women of color. I wanted them to be seen. I wanted them to be able to add their voices to the conversation. But I also firmly believe that our story is a human story. It's a feminine story, and that it transcends race. If you go to my Facebook page or you go to my Instagram page, you'll see Black, white, Asian, you name it. So many women have connected to the women in this documentary. And so we had one woman, Ada, my sister-in-law. She's on her 8th round of IVF. She has one fertilized embryo left, if I'm even saying the lingo right. Another one of my friends, Tracy, had IVF, and now she has a little one. I have another friend who's had several miscarriages, and she now has 2 children. and another friend of mine who is freezing her eggs. So I felt like, and another friend who's seeking a surrogate. She's on a waiting list. So I felt like we had the full gamut there. And last night, I didn't want to get too clinical. I didn't want to get too political. I just wanted to start out by allowing these women to share their story. And so that's what we did. If you missed it, it will air again. It's going to air on Christmas Day on December 25th at 11 p.m. Eastern. And it's also going to air the day after Christmas on December 26th at 10 p.m. Eastern. And it's also on NBC On Demand. So if you have the app, it's free of charge and you can go on and watch it anytime. And so that's my setup. If you have any questions, obviously I would be happy to answer your questions. But more importantly, I just really felt like if you have questions about fertility, I wanted you to be able to answer your questions. So with that said, I'd like to bring in some of our specialists for the evening. First of all, a huge shout out and a thank you to Dr. Valerie Montgomery Rice. We'll put her picture up. Dr. Rice is the reason that we're all here this evening. I reached out to her and I told her, I said, hey, I need your support. And she immediately responded, what do you need? I mean, she is a girl's girl, as they say in the news business. So I'm so thankful for her. She's the president and CEO of Morehouse School of Medicine, also reproductive endocrinologist and fertility specialist. So you'll hear from her in just a moment. And again, as you have questions this evening, if you put those in the chat box, we'll kind of make sure your questions are answered with the appropriate physician. Next, we have Dr. Kim Thornton, a director of the Division of Reproductive Endocrinology and Infertility at the Beth Israel Deaconess Medical Center, assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Biology, Harvard Medical School, and reproductive endocrinologist at Boston IVF. We have Dr. Gloria Richard Davis, University of Arkansas Medical Sciences, executive director, Director of Diversity, Equity, and Inclusion, Professor of Reproductive Endocrinology and Infertility in the Department of Obstetrics and Gynecology. Also tonight, we have Dr. Stephanie Thompson. If you watch the documentary, she was featured in our documentary last night. She's a reproductive endocrinologist and infertility specialist at the Institute for Reproductive Medicine and Science at St. Barnabas in Livingston, New Jersey. Also an attending physician, Department of Obstetrics and Gynecology at St. Barnabas Medical Center. And Dr. Alice Domar, Executive Director of the Domar Centers for Mind, Body, Health, Director of Integrative Care at Boston IVF, Associate Professor of Obstetrics, Gynecology, and Reproductive Biology, Harvard Medical School. So these women, know of what they speak. So with that said, Dr. Rice, feel free to take over. And then again, if you have any questions about fertility, any questions about the documentary, please feel free to put it in the chat.
So good evening, everyone. And it's so exciting to be with everyone. And thank you, Chanel, for the work that you have been drawn to do on behalf of women. It matters. So I have the easy job today to talk about what is infertility. So infertility, guys, is defined as not being able to get pregnant or conceive after 1 year of unprotected sex. We know that 6% of married women aged 15 to 44 in the United States are unable to get pregnant after 1 year. And we know that 12% of women aged 15 to 44 in the United States have difficulty getting pregnant or carrying a pregnancy to term. The other interesting thing we know is that both men and women can contribute to infertility. Many couples will struggle with infertility and seek help to become pregnant, but it's always sometimes thought about as only a woman problem. And we know that's not the issue. And about 35% of couples with infertility, a male factor is identified along with the female factor. And about 8% of couples with infertility, a male factor is the only identifiable cause. Now, because infertility in women is known to decline steadily, because fertility is known to decline steadily with age, we recommend that women who are age 35 years or older come and see a doctor after 6 months of unprotected sex. A lot of times people say, well, what type of doctor should I see? We really do recommend that women see reproductive endocrinologists in consultation with their gynecologist because they can help with identifying the cause of infertility, and also if a woman is having fibroids or recurrent pregnancy loss, which is defined as having 2 or more consecutive miscarriages, and reproductive endocrinologist is someone that they should be able to see. So that's the basic definition of infertility. I also want to just talk about in this day and time, just COVID-19 and infertility. So let me start with this statement first. There is no evidence that the vaccine can lead to a loss of fertility. There is no evidence that the vaccine can lead to a loss of fertility. Now, while infertility was not specifically studied in the clinical trials of the vaccine, no loss of fertility has been reported among trial participants or among the millions of people who have received the vaccine since it's been authorized. We have not also seen any signs of infertility in animal studies. We know that there is vaccine hesitancy there, but I want women to be informed and to know that the studies have not shown any evidence that vaccine can lead to a loss of fertility. What we have seen, though, is that COVID-19 infection puts pregnant women at an increased risk of severe complications and even death. Yet, only 22% of Black women who are pregnant are vaccinated. I'm going to say that again. Wow. Only 22% of Black women who are pregnant have received the vaccine. But when they get COVID-19, they have an increased risk of having complications that put them in the ICU. And they also have an increased risk for preterm birth, delivering the baby earlier than 37 weeks. So what we are stressing to women is that pregnant women should be in consultation with their doctor to get the vaccine, so that we know that once you've had that infertility treatment and you're successful, we do not want COVID-19 to be a challenge for you because you have not gotten vaccinated. And we'll be happy to take additional questions around this as we get into more discussion. So Chanel, that's my introduction, and I'll let you go to the next panelist.
So I'll tell you what we're going to do really quickly, because I forgot our organizers have this video just to kind of set up what it looked like yesterday, what you watched. And I haven't seen the clip, but it'll give you an idea, and then we'll move on to our next panelist. Here's a quick clip.
Is one of the top stressors in terms of a medical diagnosis.
You will look at the price tag and be intimidated.
$13,000 for one IVF.
I'm too young for that. My future's ahead of me.
I realized I was having a miscarriage.
I couldn't achieve my way out of this. We have been trying for 10 years.
Every woman has a story.
This is ours.
Oh my goodness, I hear that and I get chills every single time. I really do, just because I firmly believe that every woman has a story. I see your questions are starting to come in. As soon as our panelists introduce themselves, we'll get right to your questions. So with that, let's bring in Dr. Kim Thornton. Good evening.
Good evening, everyone. I was actually tasked with talking about some of the common treatments for infertility. And one of the things that I'll mention just right off the bat is that in many instances, the treatments may vary from individual to individual and is oftentimes targeted towards the specific cause of infertility. But for many individuals, you're going to hear about common treatments if you speak with your physician. Those treatments will include ovarian stimulation with either oral medications or injectable medications, oftentimes combined with a procedure called intrauterine insemination. The purpose of medications is to really stimulate the ovary to produce somewhere between 1 to maybe as many as 2 to 3 follicles, and combine that with inseminations where using either partner's sperm or frozen donor sperm, the sperm sample is washed, concentrated, and then placed higher up in the female reproductive tract. The advantage of that is it really places sperm closer to the site where fertilization occurs, and hopefully will enhance fertilization of eggs and therefore the likelihood of pregnancy. With intrauterine inseminations combined with some form of ovulation and stimulation, success rates are typically quoted somewhere between 10 and 15%. In many instances, this conservative approach, the ovarian stimulation, and intrauterine insemination is not successful. And in that case, oftentimes you'll be directed to move on to a more aggressive treatment with in vitro fertilization. Other couples may be directed to IVF initially, especially in instances where there is evidence of tubal blockage, if there is evidence of severe male factor infertility, or other causes that would, warrant a more aggressive approach. With IVF, we're trying to stimulate multiple ovarian follicles and therefore multiple eggs to develop. And so women are given the injectable medications, which directly stimulate the ovary to produce multiple eggs. After a period of about 9 to 12 days of monitoring, where you have ultrasounds and blood work so we can actually see how those follicles are developing, an egg retrieval is performed under anesthesia. The eggs are harvested and then fertilized in the laboratory. At that point, those eggs are grown, or the resulting embryos rather, are grown in culture for a period of somewhere between 3 to 5 days, at which point typically one embryo is transferred back into the uterus. In some instances, you can also do genetic testing of embryos at this stage rather than transfer those embryos back. And the benefit of genetic testing of embryos is that when you do ultimately have a frozen embryo transfer, you know that you're transferring back an embryo that's chromosomally normal, and therefore will have a higher likelihood of success. So that's just a brief overview of some of the common treatments that you might face in your discussion with your provider. Thank you.
Thank you. I see your questions about adenomyosis. I see your questions about unblocking fallopian tubes. So we're going to get to those in just a moment. I want to bring in Dr. Richard Davis. She's going to quickly talk about some common factors that impact fertility.
Thanks so much. So I was tasked with really covering some of the common factors that affect Black women, such as uterine fibroids, aging, and male factor. So we know that Black women bear a significant burden of uterine fibroids. It affects upwards of 80%, and it can cause heavy menstrual bleeding, pain, anemia, and yes, sometimes infertility. Fibroids impairs infertility when located inside of the uterus, so in the cavity where implantation occurs. They can also be in the wall of the uterus, which is where they are most commonly, which is an intramural location.
Dr. Richard, can you scoot a little closer to the microphone? I'm sorry, we're having a tough time hearing you there.
How about now?
They're better, much better.
Okay, all right. So, so fibroids in the wall of the uterus, if they are larger, may in fact impair fertility. But we also know that very often women have fibroids and they can still conceive and carry a healthy pregnancy. During pregnancy, the complications or potential complications from fibroids would include things like preterm labor, miscarriage, abnormal presentation, abnormal bleeding. So for women who have fibroids and it is impairing their fertility, then we would recommend just removing the fibroid. So a myomectomy, which is uterine sparing, not a hysterectomy, which would then allow them to go on and carry a pregnancy. The next thing I want to talk about is really aging. And that becomes important because what we know, data shows that we as Black women show up later for fertility care. We try to conceive on our own longer before seeking treatment, thereby entering care later than white women by a year or longer. And when we are moved to action and seek care, there are barriers to getting an appointment, getting a referral to a reproductive endocrinologist and infertility specialist, taking time off from work, and affording treatment. Even in states that mandates fertility coverage and across all socioeconomic status, these delays exist. For women 30 plus, that year of time is very critical because time in the fertility world is definitely not our friend. Once we have diminished ovarian reserve, or we start to exhaust, or we've exhausted our supplies of eggs, technology or medications cannot reverse the effect of aging. So it is crucial that we understand that and that we seek care earlier. And then lastly is male factor. Many times people think of infertility and we immediately turn to the female. Well, and oftentimes women will come in assuming that it's all their issue, but it's not. In general, about 50% of infertility may be due to female factor alone. But from a male's perspective, they account for 20 to 30% of the problem. And the remaining 20 to 30% is a combination of male and female infertility. There's a recent study from the Veterans Administration, which showed for male infertility, there's no geographic trend, and that actually Hispanic men followed by Black men were the highest group seeking treatment. So again, it's very easy to screen men for male factor by simple semen analysis. Please do not let that be a barrier or cause there to be a delay in evaluation and moving towards treatment. So again, this was just a very high level view of some of the infertility factors experienced by Black women.
Thank you. Thank you. Dr. Stephanie Thompson, I'm going to throw you a curveball. She was in our documentary last night. She's going to talk about preventative strategies such as egg freezing, third-party reproductive options, and when to decide to act. And one of the questions that we have this evening says, how old is too old to harvest your eggs? So somehow in your presentation, if you could start answering some of these questions, that's a good one.
Sure. Absolutely. Hi, everyone. First of all, if you have not had an opportunity to watch the documentary, Stories We Tell, The Fertility Secret, I encourage you to run, not walk. And you will see so many women such as yourselves and the stories that they tell. And you will really feel like we're not alone in terms of fertility and seeking fertility care. So I'm just going to talk to you a little bit about a hot topic of egg freezing. As Dr. Richard Davis said, age is one of the most important factors in fertility. We're born with all of our eggs as women. And so over time, we lose the quantity and quality of our eggs. And that really accelerates starting around age 35 and gets pretty dramatic once you get into your 40s. So egg freezing is one of the tools, really the only tool that we have to do what we call fertility preservation. And that is to literally freeze our eggs at the age that we are currently with hopes for a better chance of pregnancy in the future. The way egg freezing works is essentially taking hormone stimulation for approximately a week and a half to 2 weeks. And then we remove the eggs from you, trying to get as many eggs as possible at one time after taking those 1.5 to 2 weeks of hormone stimulation. The eggs are removed in the operating room and they're frozen. How many eggs you freeze depends on your age, something called your ovarian reserve, which is, a marker of the number of eggs that you were born with. And just like different people will go through menopause at different times, someone at 50, someone else at 60, some women will start to lose their reserve earlier on in their earlier 30s rather than later. And that definitely is impactful in terms of how many eggs you would make when you choose to freeze your eggs. Egg freezing is a very personal conversation, to answer the question of at what age should you not consider freezing your eggs. Everyone deserves a consult and to have the conversation because there's a lot of other things that come up in terms of your fertility when you meet with a fertility specialist. The best outcomes for egg freezing are generally if you freeze your eggs before the age of 35. Egg freezing between 35 to 40 absolutely can yield a live birth of a child. But your ovarian reserve and your individual factors will definitely help to predict whether or not you would end up with a live birth because it does depend on the number of eggs that you have and what that looks like in the end. For women in their early 40s, up until the age of about 42 to 43, again, it's something that could be individual conversation and weighing the risk and benefits to that. Also, different centers and areas of the country will generally have an age at which they no longer offer egg freezing. However, in your early 40s that you need a very large amount of eggs to have success from egg freezing. So again, it's an individual conversation. I also just want to touch on the fact that there are many ways to build a family. So, I think as minorities, we often don't look into other options as much in terms of, for example, egg donation, which is something that's not really talked about in our community. And that is getting an egg from a younger person, whether it be somebody who froze their eggs with the intention of donating them, or is actually doing IVF at the same time. We would be preparing your uterus to receive an embryo, which is a combination of sperm and eggs together. Egg donation is something that is a very viable option for women who are older and whose eggs are no longer going to yield a successful pregnancy. Sperm donation as well is something that we do a lot of in the majority of our clinics. And we as fertility specialists are here to help you build a family, whether you're a same-sex couple, single mother, single father, however you want to do that. There are also resources for adoption if that's a route that you choose to go down, as well as the use of a gestational carrier, if need be, for medical indications such as fibroids as well. So when to act is always when you think of it. The best time to address this is now. So if you are even having a thought of talking to a doctor about egg freezing, or think you might want to become pregnant in the near future, it's always appropriate to have a consult. Thank you.
That was great. Okay, I see your questions coming in. Again, if you have any fertility questions, now's the time to go ahead and put those in the chat. We're going to bring in Dr. Domar to talk a bit about mental health, and then we'll dig into some of your questions. Good evening.
Hey, everybody. Thank you so much. I also want to give a shout out to the women who were included in the documentary, because so many of my patients, or so many, individuals, couples, won't talk about their infertility. They feel like it's a shameful secret. And I'm trying so hard to get it out of the closet, per se. So, a couple things I want to talk about. I've been researching the relationship between stress and infertility for pretty much my whole career. And I think it was actually mentioned in the documentary last night that infertility represents a really acute and horrific stressor. And I published a paper years ago that showed that women with infertility reported the same level of anxiety and depression as did women with cancer, AIDS, or heart disease. And I think that's a shocking study for people who don't know about infertility. People on the street are like, oh, there's no way. But if you talk to anyone who's going through it or has been through it, they're like, yeah, I feel awful. I feel completely out of control of my life. And then people would ask me, why is infertility so stressful? And it's so stressful because it impacts every area of your life. It affects your relationship with your partner, if you have a partner. It affects your sex life, because couples start to associate sex with failure. It affects your relationship with your family, because there's a pretty good chance your siblings are having babies, and that can be really hard. It affects your relationship with your friends, because your friends are also probably having babies, and that's just as hard. It can affect your job, your career, because you have to miss work. And, when someone's doing a cycle, they have to be at the clinic first thing in the morning for monitoring. And that means they get late to work, or they can't fly, or they can't travel for their job. Or, when you're going through infertility, being around pregnant people can be really tough. And you can be at work and the person in the next cubicle might be pregnant, and that's all they talk about. Or you could be in a profession, like you could be an obstetrician, or you could be a pediatrician, or a labor and delivery room nurse, where you really can't get away from it. It affects your financial security, because in most states in this country, there is not a mandated benefit. And, access to care is getting better in terms of companies providing infertility coverage, but it's still atrocious how few people in this country have insurance coverage. And finally, it can affect your relationship with God. We've done research on this. And, a lot of women going through infertility say it's the first time God hasn't answered their prayers. And that can put somebody not just in an infertility crisis, but also in a spiritual crisis as well. So there are a lot of reasons why someone going through infertility, is feeling anxious and depressed. In fact, most women with infertility, sort of score above the cutoff for clinical levels of anxiety and depression. And we've done some research, and even at the first surge of COVID, our infertility patients still were far more focused on infertility than they were on COVID, because it's so all-encompassing. And so the last thing I want to talk about is this concept of access to care. And I was so impressed with the women who were in the documentary, but was remarkable is all of them had seen an infertility specialist, and all of them were working towards a resolution to have a baby through an infertility specialist. And yet, because access to care is a problem financially, but we know that even in states like Massachusetts, where I practice, which has a mandated benefit, we're still seeing fewer Black women than there are in the general population. And we also know that one of the reasons that people don't ever see a physician when they're struggling is because they're anxious about it, or they're embarrassed about it, or there just feels like there's a psychological barrier to it. And I would really encourage everybody listening to this that, if you've been trying for over, 6 months or 12 months or wherever your age puts you, please do seek out an infertility specialist, because the treatments that my colleagues have described are incredibly successful. And we really do see miracles every day.
That was absolutely beautiful. It's, there are so many layers to this. I think that's part of the reason why I did have Women of Color, is because I'm hoping that young women who didn't even consider it, or who have been isolated and thought maybe, I don't know, they didn't want to try, hopefully by hearing these women that they'll step forward. So Dr. Rice, with that, let's dig into some questions. I'll let you navigate.
So we have a question here, and I'm going to push to Dr. Rashard Davis. And the question is, can adenomyosis stop a woman from getting pregnant? So we probably first got to explain what adenomyosis is. So take it away, please.
And make sure you come closer to your mic. For some reason, yours is loud.
Okay, you're muted now. So unmute.
How about now?
Okay, can you come a little closer or scoot the mic? There we go.
How about now?
Better.
Okay. All right. So adenomyosis is really a variant of endometriosis, where the endometrial glands actually grows into the myometrial wall. And clinically, it usually presents with women having very painful, heavy bleeding. In terms of its impact on fertility, the verdict is still very unclear on that. There are some studies to suggest that it may adversely impact implantation, because there are some of the proteins where the embryo needs to attach, and they may not be synchronized or aligned correctly. So that's the short version of, there may be some impact on fertility related to adenomyosis, but we're not 100% sure. There are people with adenomyosis that have very mild adenomyosis, and it's not even diagnosed until much later.
Great. Thank you. Thank you. So another question I see here is, and I can take this one, does the Covet vaccine affect women's hormones? So all of us heard probably in October, there was a small study that came out that talked about women taking the vaccine and having lighter or shorter menstrual cycles. Now, one of the things we need to know is that irregular cycles can come about from a lot of different things. Many of us can think about times when we've been stressed or had a lot of anxiety, had depression or depressive-like symptoms, and noticed that we skipped a cycle or our cycle was different. So at this point, there have been no significant alterations that have been found in what we call sex hormone levels, estrogen and progesterone, or anti-malarial hormone levels when people have had COVID or with the vaccine. However, there's a big study that's going on right now by the National Institute of Child Health Development that is a partnership with 4 different schools, and they are looking at the impact of the COVID-19 vaccine on the disruption of menstrual cycles. Now, we all know that we have to have estrogen and progesterone. Estrogen comes from the follicles. That's what builds up the lining. And then they start to produce progesterone. And when you don't get pregnant, the progesterone level drops and you shed that lining. That's what a cycle is. That's what your period really is. And so we're going to be able to now follow women who've had the vaccine and to see if there are any menstrual irregularities. They're going to take blood and saliva and urine from these women. And so they will be checking the hormone levels to determine if it is disruptive. But so far, we have not seen anything that would lead us to think that the vaccine is going to negatively impact women's hormones. Next question I'm going to give to Dr. Thornton. Dr. Thornton, and they asked the question, is the AMH test for ovarian reserve? And you probably want to tell them what AMH is and what's the significance of it and what is ovarian reserve?
Right. Thanks. What I think I will address is ovarian reserve in general. Ovarian reserve gives us a way to really assess how many follicles and therefore how many eggs you are likely to produce in any given cycle if we were going to stimulate you. And it also gives us a sense, for instance, if your ovarian reserve is diminished, it doesn't necessarily mean that you won't have success with fertility treatment, but it's going to mean that we're going to have to work a little harder to get really good quality eggs. That being said, the testing that you do for ovarian reserve is blood work on day 3 that includes hormonal testing, pituitary hormone, follicle stimulating hormone, which always needs to be paired with an estradiol. And then the anti-Müllerian hormone is a glycoprotein hormone that's produced from the small follicles within an ovary at its baseline resting state, if you will. And it gives us an idea if there are lots of follicles that would respond to stimulation or not. Most individuals with an AMH over 1, that's considered normal. AMH levels less than 1, that's considered to be diminished. And those numbers may vary depending on your laboratory. The last test that is oftentimes done to assess ovarian reserve is an ultrasound, where you can do what's called an antral follicle count, actually count the small follicles that are in the ovary at the resting state. And those values altogether can give you a good sense of ovarian reserve, i.e. the number of eggs that you might have available to you on your fertility journey.
So Dr. Thornton, let's say that I am 25 years old and I just got married and we're thinking about trying to get pregnant. And I've never had any problems with my cycle or anything. Before I start trying, should I get an AMH, or when should I get an AMH to really look at my ovarian reserve?
I think for someone who's 25, I would recommend that you just start trying to conceive. Until you have a diagnosis of infertility, if you will, there's no need to go down, a road of just testing. More than likely, you're not going to have any difficulty. But if you've had difficulty conceiving after a year, then I would go ahead and, start to do that testing.
Even if I'm 25?
If you've had infertility after a year and you've been actively trying, you should go ahead and seek an evaluation, because there may be other factors. Your ovarian reserve may be fine. You may find out, your partner has problems with his sperm, or your tubes may be blocked. Right. So the key is not to delay in doing that evaluation.
Right. So Dr. Thompson, here's a question. I'm not familiar with egg donation. Would the baby have the same DNA as the carrier?
So egg donation is the concept of having an egg from a younger person, generally somebody under the age of 30, fertilized generally with your partner's sperm, grown into an embryo, and then implanted or transferred into you as the intended parent. So the egg from the egg donor does not have your DNA. It would have the DNA of the sperm donor partner, whoever that may be. So there is thought to be, though, as you carry a pregnancy for 10 months, that there could be some epigenetic just transfer, because we know that there's so much impact of the mom, even from mental health studies, and impact on a fetus that's growing. So I do feel like there probably still is some connection, to the baby and to carrying the pregnancy, although they don't technically carry your DNA.
And so I think you mean, we may want to explain what epigenetics mean when you said epigenetics. Mm-hmm. You talked about the environment that the embryo is growing in?
The environment that the embryo is growing in, exactly.
Great. Okay, great. Thank you. So another good question here. What are the treatments needed to prepare for egg harvesting? I'm in graduate school and it's not covered, so the cost is very restrictive. I think, Kim, did you talk about this a little bit?
It sounds like the question is asking about egg freezing.
Mm-hmm.
And so that if you are considering egg freezing, your reproductive endocrinologist will do your ovarian reserve testing and then talk to you about the ovarian stimulation required to stimulate the ovary to produce the multiple follicles. Other than that, there's not a lot of preparation that you need before an egg freeze cycle. And I think that one of the benefits of speaking with your provider, oftentimes they will have financial coordinators that can help you navigate, kind of the finances regarding, egg freezing. There are, certainly programs that can provide loans, etc. So, you need to just look into all of your resources, and there are people in most practices to help you do that.
Is there a time that you're too old to freeze your eggs? Is there an age where you're too old to freeze your eggs? Anyone can answer that. Y'all all are smiling.
I think Stephanie addressed that. I will say that I think that, as women get older, the one thing that we have to be mindful of is the fact that the embryos that result from eggs from older women have a higher likelihood of chromosomal abnormalities. Mm-hmm. So as Dr. Thompson mentioned, if you're freezing eggs, at the age of 40 or above, the number of eggs that you need to have a successful pregnancy is, probably going to exceed 30 or 40 eggs. So then you have to weigh, cost benefit. So, I think that most programs have an upper limit where they would not recommend egg freezing. I think in our program, it's in your probably early 40s. That being said, there's still some people who want to try. And I think as long as you're well counseled, you may find providers that are willing to help you freeze your eggs.
Thank you. Anybody else want to comment on that?
There are also some great, so go ahead.
Oh, I was about to say, I think also understanding that the data we have in IVF shows us that success rates drops with age. And so the younger you freeze your eggs, the higher the probability of success. Egg freezing, we don't really know until the eggs are thawed and you attempt fertilization and pregnancy exactly how successful it is. But we do know that the younger you are that you freeze eggs, the better the success.
Stephanie?
There's some good calculators out there online, several that can kind of help you to get an idea of what the live birth rate would be from frozen eggs. Obviously some of them are extrapolated, but it gives you a good general idea of how many eggs you would need at what age to be successful with a live birth. So that's a great tool as well.
So Alice, trying to get to some questions to think about here, because you have counseled many women who were coming in, and couples or women coming in to seek individual care, and they want to talk about, what should I look for in a fertility specialist? What advice would you give them? Because we're all fertility specialists, so we may be biased.
Oh yeah, of course. I'd say two things. One is you want to find someone, if you can, who's a board certified, what they call REI, reproductive endocrinologist and fertility, which means they did they went to medical school, and then they did their OBGYN residency, and then they did a 3-year fellowship in infertility. And that's someone who I consider a true specialist in fertility. Now, you can have any kind of physician who can call themselves an infertility specialist, but you really want to look and make sure that they are an REI and they're board certified. So that's sort of if there's one within an hour or two of you, that would be obviously easier for you. The second thing I would say is I think it's kind of a chemistry thing. I mean, I work at Boston IVF. Kim Thornton is one of the physicians there. I know all the physicians, and I think that sometimes that you just want to have a physician that you feel comfortable asking questions, because I think, today's women who see an infertility doctor tend to be very well educated. They spend a lot of time online researching what might be wrong with them and what treatments they want. And so they have to have a physician who is going to respect their style. And so, you might need to see more than one physician, even within the same practice, who just feels like you guys click. I mean, we have some physicians who are, the super nerds who do all the research and, they love having really intellectual discussions with patients. And we have some physicians who are more warm and fuzzy for the patients who sort of need a handheld. And so I think you have to kind of figure out what you want in a physician and then seek out a physician who will match your style.
All right, great. And Gloria, I think that there are resources. Where is the resource, the most comprehensive resource that a patient can go to find a reproductive endocrinologist, infertility specialist who meets the criteria that Alice talked about?
Yeah. So the American Society of Reproductive Medicine is our parent organization, and that's asrm.org. Within ASRM, we have the Society of Reproductive Endocrinology and Infertility Specialists, which in order to belong to that organization, you have to be board certified. So those are two easy, accessible database that patients can seek out.
So maybe we can put that in the chat so that patients can know asrm.org and then SREI. So we can put that in the chat so that patients will know. Now, I actually would like for everybody to kind of make a comment on this. And Chanel, I actually want to hear your thoughts about this too, because you did this wonderful documentary. What is the best way to alleviate the stigma around infertility? And Chanel, we'll start with you because you have a different perspective than maybe what we have.
I think it's doing what we're doing right now. And I think it's all hands on deck. So I think the mom community, for example, I have 3 little ones. I have 2 9-year-olds and a 12-year-old. And for their entire lives, it's been mom blogs and parent magazine and mom groups. And I'm in Jack and Jill. There are all these groups designed for moms. And I think that's fine. But I think sometimes perhaps we as a group and as a community can be a bridge to our sisters who are still trying. And I don't know what that would mean. I don't know if that is, having more discussions like this. I don't know what it would be, but I do think sometimes that if we come together, that I just don't want them to feel so isolated. That's one. And I also think, look, I'm a storyteller, and I've said I really do believe that there is a transformative power in storytelling. It's a beauty to me of news. And so, and of journalism. And so I think for documentaries like last night, I could have gone the clinical route, but I'm not PBS. I'm not a doctor. I'm not a researcher. So I just wanted people to meet these women and hear their stories as human beings and as women. And then when you hear about legislation, or you hear about, the need for maternal health funding, or you hear about the maternal health crisis, I think for me, you can start to win the hearts and minds of people and society at large, so they can start to hear these issues and not divorce themselves from it, when you can start to put a name and a face to some of these issues. And so now when you talk about fibroids, they may think of Ada, or when you start hearing about surrogacy and funding for surrogacy, or whether your company will cover it, then maybe some of these CEOs and executives who maybe don't understand what's happening can hear stories like this. And so last night was really for everybody. I was hoping that women of color could see themselves finally on prime time, but I also wanted it to be for everybody so that we can start to have these conversations. And I think the more and more we start to have these conversations, I'm hoping that women don't have to carry such a secret. And, we talk about in the documentary, if you have a loss, whether it's a relative, even a pet, you go to work and you talk about it, you get a couple of days off, there are cards, and people will say, oh, I hope you're okay. And you can publicly grieve. If you have a miscarriage, there are women who will tuck it and go to work the next day. And I just think, how did we get to this place? And as women, we have enough power to say enough is enough. And start to tear down these walls. And so I just think it's going to take a little time, but I think one day at a time, and with sessions like this and with documentaries like last night, I really think that we can start to move the needle. And I also think for women of color, I didn't even realize that they weren't seeking, fertility specialists as often, so there's so many issues that even I didn't realize by doing this documentary. But all it takes is sowing a seed, for a mother to hear, wait a minute, my daughter's having problems. And I was going to ask one of you guys, one of the girls in our documentary didn't find out she had endometriosis until she was in her 30s, because obviously I think you discover it with exploratory surgery. Is that something that you should try to diagnose earlier and then try to freeze your eggs earlier? I've always wondered about that, because I have so many women who've reached out to me over the last 72 hours who have endometriosis, and they didn't find out until later. And they're asking me, and I don't know the answer to that. If they would have found out earlier, is there anything they could have done? And moms are asking.
So both Gloria and Stephanie can tackle that. So we'll start with Gloria.
So I'm so happy that you brought this up. And one of the things that I was talking to Kim earlier about is the average length of time that it takes for a woman to be diagnosed with endometriosis is average 8 years, which is tremendous. Like you pointed out, because it is a surgical diagnosis. And so we don't want to do surgery unnecessarily, but there are some algorithms that we follow for women who have severe menstrual cramping, who have pain with intercourse, or who have infertility for other unexplained reasons. Then that's an indication for laparoscopy. I think young women who are really burdened by painful menstrual cycles and they're not getting relief from the standard methodology or standard treatment options should definitely undergo laparoscopy. And that gets us to the diagnosis. But also remember that not everyone who has endometriosis will have infertility either. But 40% of the women with a diagnosis of infertility will have endometriosis at varying stages.
Stephanie, anything to add to that?
I would just add that endometriosis is really tough. It's one of the toughest things that we deal with in fertility. And so an early diagnosis is important. But sometimes people with the worst endometriosis don't have any pelvic pain. So it can make it very, very difficult to know that that's what is really going on. And I think Dr. Thornton made the point earlier that yes, even if you're 25, you should come to see a fertility specialist if you've been trying for a year, because that is something that we see probably more commonly in younger people when you would think, okay, you're young, it should happen, what's going on? And endometriosis, especially in the minority communities, that's not the classic teaching in medical school that minorities are affected with endometriosis. We hear more about fibroids. So I think education and advocacy are also extremely important.
There was a question really quickly that someone asked at 7-Eleven. Well, the first question we have, it says, is there a natural way to unblock fallopian tubes?
So I can address that.
I think we're pausing because all of us are thinking we've all done a lot of tubal surgery early on. So yes. Early on when we were training, now we're a little bit old, but early on when we were training, we did all type of laparoscopic surgery trying to open up the fallopian tube. But one of the things that happens is it just closed back up. And so I'll let people who are still operating answer that question. But to my knowledge, there's no way that a natural way to unblock fallopian tube.
Yeah, I would echo that. I think that, the type of tubal blockage that most people are diagnosed with, it's a structural blockage, either as a result of an infection or previous surgery or severe endometriosis that either causes, a complete occlusion of the end of the tube, which, in some instances you can try to open that tube up, but it's not particularly functional. And nowadays, with success rates with IVF being so much better, it's not necessarily indicated to do that kind of extensive microsurgery. Certainly, if the ends of the fallopian tube seem normal and it's just that they're surrounded by scar tissue, you can oftentimes still go in and remove that scar tissue. In other instances, the tubes are blocked where they connect to the uterus. And sometimes it's a real obstruction, meaning that you can't open up that area. And in some instances, just doing things like hysterosalpingograms and pushing dye or fluid through the tubes can remove mucus plugs, but no real natural way to unblock tubes, if you will.
And Kim, if I've had an infection and my tubes are blocked, and they do that HSG procedure that, that was being described on the documentary and how painful it could be. And they do that and my tubes are blocked. Should I have my tubes removed before I do IVF?
So one of the things that we do know is that tubes that are blocked and dilated and contain fluid that kind of just sits there, that fluid has a tendency to reflux back into the uterine cavity and cause an inflammatory or create an inflammatory environment that oftentimes will reduce implantation rates. So there is good evidence to suggest that for dilated fallopian tubes with visible hydrosalpinx, which are the dilated tubes, they should be removed, or at least it's recommended that they be removed prior to doing an IVF cycle.
And typically that can happen through laparoscopy, right?
That can be done laparoscopically.
Scar or any of that. So there are two questions here about lifestyle stuff. And so the question, I'm going to combine these. One says, what lifestyle changes should one make to best support fertility and or preparation for having one's eggs harvested? And then the other one was, are there any vitamins that can improve a woman's ovarian reserve and egg quality? Stephanie, you want to take a stab?
Sure, I will. So I will start with the preparation for having your eggs frozen or infertility treatment in general. The first thing, I do think we have a huge epidemic in this country of obesity and, being overweight. And that is probably one of the top things that you can address in terms of outcomes for future pregnancy and fertility. So I think, optimizing your weight and optimizing your health in that way is probably, the first priority. Being overweight can affect your menstrual cycles. You may not ovulate regularly. So there's a lot of things that can come with that. So that regular exercise, and you don't, have to go crazy and be on the Peloton, but at least walk outside, do some moderate exercise, just be active. So many of us are just sitting at our desk all day long these days. So it's very important to continue to be active. We definitely want to get 7 to 9 hours of rest a night. I know something also very difficult to achieve these days. And make sure that we're trying to keep our stress levels, as reasonable as possible. Again, especially in the middle of this pandemic, there's so many things that we are all facing. And, we want to try and de-stress as much as possible with that. And then in terms of, are there any vitamins or other things that we can do to try and improve ovarian reserve? There's a lot of stuff out there on the internet. And, again, age is the most important factor in ovarian reserve and egg quality. Some of our patients will recommend coenzyme Q10, which is an antioxidant. In mice, it helps with ovarian aging. And you may also see supplements like ovositol that can help for women with PCOS in general. There's things you'll see, DHEA. There's a lot of data that's controversial on some of these vitamins and minerals. I think really I would take your list to your fertility specialist and, run through that before taking anything.
Right. That's a good suggestion. Building that relationship with your fertility specialist so that you can have some of those difficult conversations. All of us have had to have these lifestyle conversations. And we're going to be honest, particularly with Black women, because Black women, we have more obesity. We see that. We have more fibroids, we have more obesity. And those are two of the factors that really do impact our fertility. And we have to have that conversation about getting to a healthy weight, not just to get pregnant, but once you get pregnant, so that you can not end up having diabetes. One person asked a question, does diabetes or being a pre-diabetic, impact fertility? Gloria?
So we have patients who have polycystic ovarian syndrome, which is, I oftentimes refer to it as a pre-diabetic. Oftentimes there are ovulatory disruptions that's associated with that. But again, it is more associated with the obesity, the adipose cells, which produces estrogen that can disrupt ovulation. But what's probably more important in terms of diabetes is, should you get pregnant, there are significant risks to the baby if your diabetes is uncontrolled. So I want to step back and talk about preconception counseling, because I think that's something that we don't do enough of. Is many women are not using contraception, and they're not necessarily planning a pregnancy, but we have to act as if they are. So we need to have those conversations about optimizing your health, about taking folic acid, about things that we know that you can do, which improves your ability to get pregnant and have a successful pregnancy with less impact or less risk to the baby.
Thank you. Thank you. Kim, there was a question here about what are your thoughts on the reliability of Pgta testing of the embryos? And you probably want to explain what Pgta is first.
Sure. So Pgta is pre-implantation genetic testing of embryos for aneuploidy. And aneuploidy is where you screen embryos for numerical chromosomal abnormalities such as trisomy 21 or trisomy 16, for example, conditions that tend to result in pregnancies that either miscarry with a high frequency or could result in a live birth that has some developmental abnormalities, but related to aberrations in the number of chromosomes in the embryo. The data seems to support that Pgta is probably most effective if used in older women. So I think most of the studies suggest women over the age of 38. In women who have recurrent pregnancy loss, where the recurrent pregnancy loss is thought to be related to genetic abnormalities of the embryo. And then there are lots of individuals who just for whatever reason are not comfortable transferring embryos that could potentially be chromosomally abnormal, so that they may elect to do Pgta testing of their embryos. With the more advanced testing, the reliability, I would say, in terms of diagnosing an abnormality is in the 98 to 99% range. So I think it's reliable. The question is it necessary? So for instance, a 25-year-old, I don't usually recommend Pgta testing because she's young. Her embryos, the majority of her embryos are going to be chromosomally normal. That's very different from a 40-year-old, where I might make that recommendation because she's going to have a disproportionately higher number of chromosomally abnormal embryos, and it might reduce the risk of transferring an abnormal embryo and having her run the risk of suffering a miscarriage or having to do further diagnostic testing down the line.
I will say too, this is so great that we're having this discussion because you guys are in it and I'm kind of on the outside looking in. And I have to tell you, we see celebrities having babies in their 40s. And so when we're getting married and we're getting married late and we're saying, oh, we want to put it off for a few years because I want to make partner, I want to do this, or I want to do this with my life, I want to travel. No, there's a lot of women just aren't thinking about their fertility because we just haven't had the conversation. And so when one of the questions, to kind of start to wrap this up, one of the questions talked about, how we can change this. I think part of it is just having this discussion, because now every person who's listened to us tonight, every person who's watched this documentary, they now know, once knowledge is power. Once you recognize that, wait a minute, maybe I should, start talking about my fertility. If I'm, for the viewers who are maybe in their 20s, it's time to start thinking about it. It seems like a no-brainer now, but I'm telling you, most women, we see these celebrities having kids, and so we just don't think that we will have any trouble. So I think, conversations like this will definitely move the needle. And even
can I answer one question though? Sure. I think this is really important. Someone said, do you think that COVID is the cause of so many infant deaths and miscarriages? And they probably saw an article that was in British Medical Journal that talked about that there was likely an extra 267,000 infant deaths in the world now in 2020, prompted by the COVID-19 economic downturn. So the chances, you all, of COVID being passed to an infant from a pregnant mother who may have COVID is very low, okay? And so when you're looking at this, what we think is happening, particularly in these countries that have experienced what we call income shock, is that they were already impoverished countries, and now the poverty is even worse. And we know that the most important time in a baby's life, or where they're going to make it, is really in those first 3 to 6 months. And so if you have babies being born in poverty, and we know that we saw a lot of economic downturn, particularly in low and middle income countries, we are seeing now the indirect impact of COVID on the economy, and that is impacting the level of poverty in countries, because that's what we believe that this excess death is related to. So I wanted to make sure that we talked about that, you all, because we are all right now in the middle of what we think is another wave. And I want to really stress to people that the most important thing that we can do as part of your preconceptual counseling is to get vaccinated. And if you're 6 months from your second shot, to get your booster, because we want you to have a healthy pregnancy. And we know that women who are not pregnant, who are not vaccinated and who are pregnant, compared to women who are vaccinated and pregnant, those unvaccinated women have a higher chance of getting COVID, a higher chance of complications, a higher chance of having a preterm birth. And even if you get pregnant and it's time for your booster, we would still recommend that you get your booster to protect you and your baby.
Such a wonderful conversation. It really, really is. And I think this will live on your Facebook page on blackdoctor.org. So women can come back and hear this if they weren't able to hear this live. Does anybody have any final thoughts before we wrap this up? We've reached the hour mark here.
I was just going to circle back to your comment about having the conversation, because I think it is so important for us to talk about these issues and to educate our younger women as to what they need to do, one, to protect their fertility, because we talked about blocked tubes, safe sex, preventing any sort of sexually transmitted diseases is critical. And then when you look at planning, so ASRM probably 20 years ago did public service announcements to really educate women on the impact of aging. But when they came back and asked the question of women as to whether or not they would try earlier, all of them still said they would wait because they felt like the science would have gotten better and that they could, in fact, get pregnant later. Mm-hmm. So we're here underscoring the fact that the science is not going to change age. So,
and we are actually not that good, y'all. We can't make miracles. Okay, so we can only use the technology and what you bring to the table.
That's exactly
right? So what you bring to the table is what we use along with technology and your partner, of course, to make that happen. Okay. And so we really are not miracle workers, but we have a lot of resources that we can assist you with, but you definitely do have to be engaged and be engaged earlier.
I always like to say that our biology has not caught up to our society.
Yeah.
So we as humans have not evolved for our social interactions now.
That's real. Thank you guys so much. Again, this documentary, the legs that it has, it's beyond my wildest dreams. Like I remember, gosh, when I was in my 20s, I used to go home. I worked the night side shift as a reporter. I would watch Larry King Live and eat Pop-Tarts and lean cuisines every night. And Oprah was on one night, and she looked at Larry King and she says, God has bigger dreams for you than you can dream for yourself. And I was like, oof. And I went and I typed it out and I put it in my jewelry box, and I've looked at it ever since. And it's so true. And with this documentary, that's the way it feels. I mean, I had this idea that every woman has a story. Stephanie and I are friends, and I would hear her talking about, she couldn't go into detail about these cases, but I would say, so am I crazy? Are more women waiting? And, I was always asking her all these questions. And so I thought, let's do something. So I'm so thankful for you guys and for people to see your faces, for women who may not know about fertility specialists. It's common for you guys, but for some women, it just never crosses their mind. So now they know. And I know you'll probably be hearing from a lot of women around the country. So thank you so, so much for this. Again, the documentary is called Stories We Tell, The Fertility Secret. It airs again on Christmas Day at 11 p.m. and then again the day after Christmas on the 26th, or it's streaming all the time on NBC News app. It's free. So thank you guys so much for your time. This has been wonderful. And to an organization like yours, you're changing lives day in and day out. So thank you.
Thank you.
Thank you.
My pleasure.
My pleasure.
Thank you all for your documentary and